And Umesh, you've been at the spearhead of the South African guidelines for asthma management. So please go ahead.
Well, again, thank you very much for the opportunity to participate in this masterclass. I think the case presented by Naveen was very instructive and raised a number of important issues, certainly in the context of the COVID-19 pandemic. Now, asthma has many challenges to doctors in private practice, primary care practice, to patients and to pulmonologists. It's a complex inflammatory disease, but the bottom line is that despite its complex inflammatory processes, almost all patients with asthma need anti-inflammatory treatment. And I think the take-home message here is that the anti-inflammatory medication that has universal effects in all asthmatics are corticosteroids, and for convenience and reduction in side effects, it is administered for all intents and purposes by inhalation. And I think that is very important to constantly emphasize, irrespective of where we practice, whether it is first world or third world, we still face the same challenge of patients and maybe some doctors having the so-called corticosteroid phobia. And we need to reassure our patients and our practitioners that administering inhaled corticosteroids, firstly, is the most important anti-inflammatory medication for all asthmatics, and that by inhalation it is in recommended doses absolutely safe. So there should be no problem with that. GINA, the Global Initiative in Asthma Management, has introduced guidelines, and there's several advances in the guideline. And I think the one most important advance is that in the past, we treated mild intermittent asthma with bronchodilators, i.e. salbutamol inhalation as needed. It's become quite evident that even these patients need inhaled corticosteroids on board. So we still use treatment intermittently, but the recommendation is coming out stronger and stronger with more evidence that even for symptom relief, you should administer the bronchodilator together with the inhaled corticosteroid. And I think a lot of this understanding arose out of the most recent British or UK investigation into asthma deaths. And I think everybody who manages asthma should actually take the opportunity to actually read this publication. What came out of it is quite astounding, that when you look at asthma deaths, at least 10% of patients who died from asthma were classified as mild asthma when you went into the primary care asthma medical records. So what happened, or the understanding we have, is that even mild intermittent asthma can lead to asthma deaths. So that is why there's a shift towards using a corticosteroid together with the reliever medication. That's going to be a huge challenge, particularly in resource-limited countries where bronchodilators are very cheap and available over the counter, and then adding a corticosteroid just raises the cost. So there's two challenges here. Firstly, making it accessible and affordable, and secondly, to change our mindsets in managing the acute symptoms of asthma. But I think that's a tremendous advance in the way we look at managing acute asthma symptoms. I'm not going to go through that in any great detail.
Umesh, if I can just interrupt you. If you look at the new GINA guidelines, if you go back to that slide, for a general practitioner, what would you say is the biggest take-home message from these guidelines? I mean, you did mention the mild asthma guidelines have changed, but in terms of prescription, as to what pharmacotherapy they should prescribe, what would you say has changed?
So for the very mild asthmatics, chronic medication, you must have minimum low-dose inhaled corticosteroids on a regular basis. For patients who have mild intermittent asthma, you treat intermittently, but in the past when we were giving a bronchodilator, the proposal is into the future we should be administering the bronchodilator together with the inhaled corticosteroids. So I hope in the future the pharma is paying attention and would produce the salbutamol inhalers together with the corticosteroid included in it, so there's one inhaler for reliever. So that is the most important advance.
Okay, that's clear to me. And do you think that means that's the end of the road for plain salbutamol in asthma, for adults at least?
Increasingly, yes. But I think, as I said, that management approach is so entrenched that it's going to take a generation to change. But the sooner we start, the better.
Sure. Please continue, please.
So I'll proceed. So I think the key points in the new guidelines is that mild asthma is certainly associated with increased mortality. Now, the most severe asthmatics, which is a challenge, and I think most of these patients, fortunately, would get referred to physicians with an interest in asthma or wherever available, a pulmonologist. And then there is the advent of the long-acting anticholinergics, there are biologics, and there's bronchial thermoplasty. Now, these therapeutic interventions are extremely expensive, highly specialized, and therefore this patient should be referred. Suffice to say that it's less than 10% of the asthma population that would actually need this. So the vast majority of patients can be readily managed optimally in a primary care setting. More and more, we're going to see patients even with chronic persistent asthma actually needing combination inhalers with the long-acting beta-2 agonist together with the inhaled corticosteroids. There's increasing recognition of asthma and COPD overlap. I'm not going to discuss this at all. And again, suffice to say that smokers can develop asthma and asthmatics can develop COPD when they smoke. So it's not surprising that these two diseases overlap. The take-home message there is if you suspect a combination of asthma and COPD, the simple approach is to ensure that you give a beta-2 agonist together with a corticosteroid. We know that severe asthma actually contributes to the greatest cost of asthma care. And I think there's a lot of research trying to understand the genetic basis and the pathophysiologic basis of severe asthma and how we can control these patients better. I think in 2021 and 2022, COVID-19 has really introduced a whole new insight and challenge to us in managing asthma. So just to dispense with severe asthma, because as I said, even in primary care practice, these are the patients that consume most of your resources, both in time and cost. And the commonest cause for severe asthma or asthma being difficult to control is poor adherence. And I don't think anyone can emphasize more how important it is to ensure, number one, that the inhaled corticosteroids are best administered by inhalation. It's safe, gives you the best response and minimal side effects. However, we do not pay enough attention to inhaler technique, and that is the commonest cause for poorly controlled asthma. I practice in a more first world setting, and you would think that you would not see patients with poor inhaler technique. I can still tell you that about 80% of patients who are referred to me with poorly controlled asthma actually have poor inhaler technique. So it's worth investing constant encouragement to both practitioners and patients to pay attention to inhaler techniques. But other factors that contribute to worsening asthma is rhinitis, which is about 80% of patients with asthma have allergic rhinitis. And again, in line with the United Airway concept, if you don't treat asthma, the allergic rhinitis gets worse. And if you don't treat allergic rhinitis, it either precipitates or makes asthma more difficult to control. I think occupational factors are easy to identify if you take a history, and dealing with that should not be difficult. The other challenge that I see in practice very commonly is because we have these cardioselective beta blockers routinely available, many of them have different trade names, and sometimes patients and doctors fail to recognize that these drugs are actually beta blockers. And we see many asthmatics actually having worsening in the asthma because they're on beta blockers, and that's not recognized. So we need to pay attention to that. We need to look for associated systemic diseases, certainly in our setting. And I don't know what the situation is in India, but we see many patients with hypothyroidism, but both hyper and hypothyroidism can contribute towards difficult to manage asthma. Again, in my setting, and I think it's the same experience the world over, that psychological factors do contribute to poor asthma control. So whilst you deal with the patient, the adherence to treatment, look for concomitant diseases that you need to control, you need to also look at the environment in which the patients function and deal with that so that you get better asthma control.
Naveen, a question for you here, Naveen. You saw all those factors, and I think there are all those factors. From a primary care perspective, do you think one of those factors stands out as the most important for an asthmatic whom you have given the perfect prescription but still comes back uncontrolled? Which would be the commonest?
So it's the United Airway theory, right? So when we're not treating the rhinitis, we're not treating the postnasal drips, these are the patients that will typically always come back despite using the inhalers properly. We're not treating the patient holistically or completely. We don't get a lot of patients coming through in my setting with occupational related asthma or where there's other factors. But for me, I think it's the rhinitis that's not treated.
So that's interesting. Yeah, I often see inhaler technique as an issue as well. Actually, I don't know, Umesh, even after your asthma nurse or assistant has taught them the inhaler, how often do they come back using it incorrectly?
Very frequently, and I use every doctor visit to reinforce inhaler technique, and I would advise all primary care physicians to do that. Investment in the patient's better control. You can teach your receptionist to do it, your nurse to do it, so it should not add to the consultation time.
Sure. So on that, the internal factor was the rhinitis. The external factor is 90% inhaler technique. And I do a similar exercise as Prof. Every single asthmatic patient that comes in brings in their inhaler and they demonstrate, what they do with it. And often they spraying this into their cheeks, they're exhaling and then, pressing the button. There's a whole lot of factors that they just can't figure it out. It's not as simple a device as one would think. And when we give a script to a patient, they go to a pharmacist and receives a box in a plastic, and that's it. It's still sealed, and often it still comes back to me sealed without the person knowing how to open it.
And Rajan, I also examine pulmonologist board exams, and one year I decided to bring about 10 different inhalers, and I asked the candidate who's training to be a pulmonologist, now can you show me how to use each one of these inhalers? And all of them failed, because in many of them train in the state sector where all these inhaler devices are not available, so they're not familiar with it. So for me, the important message is you're going to treat asthma. So your first responsibility is to make sure you are familiar with the inhaler devices so that you can teach the patient and instruct them and correct their technique.
Absolutely. Couldn't agree more, Umesh. Please carry on.
Right. So I think another big challenge in the context of inhaled corticosteroids in the COVID pandemic was the fear of corticosteroids. So there was initially a fear that, look, corticosteroids might make COVID worse. The fear was that asthmatics on corticosteroids now should stop using it because it might affect their outcome with COVID. And there was also a very interesting observational study that suggested that if you got COVID and you used an inhaled corticosteroid, you might mitigate the severity of COVID. And so what followed was this very good study that was published, which looked at inhaled cyclosinide in patients who developed COVID. And these are not patients who are asthmatic. And the reason I'm presenting this study is because it has numerous direct and indirect messages. So firstly, it was quite clear that using an inhaled corticosteroid, even when you're not asthmatic, when you develop COVID, did not make you worse. So it was safe. Second thing, they found that even though it was not statistically significant, some patients actually did get better, i.e., there was some evidence that an inhaled corticosteroid might mitigate the severity of the COVID infection, but that's not conclusive and we need more studies. For me, the indirect message in the study is that it confirmed that inhaled corticosteroids are safe even if you have COVID. Because there were many doctors and patients that were worried, look, I'm taking a corticosteroid, but to make my COVID worse. And I think the study indirectly has shown that even if you don't have asthma, inhaled corticosteroids are not harmful. So in the asthmatic patient, the message is that you should continue your maintenance treatment for your asthma throughout the COVID epidemic, even when you develop an active COVID infection. And I think we need to reinforce that view because patients constantly ask this question, and I'm going to show you some data about why asthma is not necessarily a risk factor for more severe COVID. And in fact, this is the information that is produced by the American College of Chest Physicians, and I just want to go through this because I think we need to reinforce this message. Asthma does not increase the risk of acquiring SARS-CoV-2 infection and developing COVID. So therefore, these patients must continue with their treatment, and in fact, the best outcome is with COVID and you got asthma is when your asthma is well controlled. Guideline-based asthma therapy should be continued, and that is even in those severe patients who need biologic who are on oral or systemic corticosteroids. You should not reduce it. And the message is, use the minimum amount of treatment that gives your patient the best asthma control, and do not let COVID dictate you reducing this patient's treatment. The next question that I think people are confronted is it safe for asthmatics to get a vaccine against COVID-19? And the answer is absolutely yes. Your asthma is well controlled, you do not have an active COVID infection, you must go and avail yourself of the vaccine, because that is the only way in which we're going to get a handle on this epidemic. The last question is, does asthma increase your risk of dying from COVID? And the answer is absolutely not, providing your asthma is well controlled and you do not have other comorbidities, i.e. an older patient, high blood pressure, dyslipidemia, diabetes and obesity. Now, unfortunately, in the Western world and even in the third world, we are seeing increasing numbers of asthmatic patients who are obese. Now, obesity itself is a risk factor for severe asthma. Obesity in itself is a risk factor for increased mortality from COVID. So I think we go back to first principles. To summarize, asthma does not confer a greater risk for dying from asthma. Well-controlled asthma improves your outcome. And we need to constantly look at the other risk factors and mitigate and work on those so that we reduce risk factors for getting severe COVID disease or dying from COVID. So just to summarize again, all patients should continue taking the asthma medication that maintain optimal control. Like you alluded to, all patients should have a written asthma management plan. And when you get acute severe asthma, the management should not be any different with or without COVID. And again, there are a lot of clinicians who believe that, you shouldn't do X and Y. Don't give them systemic corticosteroids during the viremic phase. But you are treating the asthma, not the COVID. We need to understand that. What about nebulizers? So there's a very interesting thing that has emerged. I don't know if you will recall, Sujit, but in the 80s, there were few studies that were published to compare nebulizer treatment versus administering a beta-2 agonist through a spacer in patients who come in with acute severe asthma. And all these studies showed in children and in adults, in COPD and in asthma, that there was no difference in the outcome, whether you gave the bronchodilator by nebulizer or whether you gave it through a spacer. So the message is that COVID-19 presented a risk. So if you nebulize, you were aerosolizing and increasing the risk of disseminating the virus. So in our practice, we now stopped using nebulizers in the ICU, in the wards. And in fact, none of our asthma patients actually suffered from not having that. And it reinforced the view that, we got used to a particular paradigm and don't change. And I think COVID for me has reinforced my view, and I think we should do a nice study to reaffirm that administering a bronchodilator through a spacer is just as good as nebulizing. The additional risk of aerosolizing a virus then is removed. And my observation, and I don't know what your observation is, but we did not see an increased number of patients coming in with acute asthma during COVID.
We saw exactly that, Umesh. We saw exactly that. In fact, the patients were so worried after the CDC put up asthma as a risk factor. I don't know if you recollect that. And I thought it came right on top because of A and the alphabetical order. And so that got everyone worried. First risk factor, asthma. And what you're saying completely, I would say, overrules that fear. And that's exactly what we saw in practice as well. Absolutely what you're saying. They hardly got episodes, barring severe asthmatics uncontrolled, who probably would do a little worse. But otherwise, asthma patients either were silent carriers or had very mild COVID.
And then we actually saw a decrease in acute asthma admission. Now, one possible explanation is because people were wearing masks, therefore this common respiratory viruses that were causing exacerbations were now being eliminated. But I'd like to hear Neven's view from primary care practice, what he observed, whether he concurs that we saw fewer acute severe asthmatics.
No, absolutely, Prof. We saw far less exacerbations, far less acute asthma attacks. We often wondered whether the patients just weren't coming in because they were afraid of picking up COVID from everybody else or anybody else that had flu-like illness. But I concur that we definitely had fewer bouts of exacerbations in asthma.
Okay, so if I can just continue, what about spirometry? And I think, we always recommend that you should have an objective measure of your asthma control, and the best way to do that is with spirometry. In primary care practice, it's the peak flow meter, but I think in the context of the COVID pandemic and during the severe waves of infection, I would advise against spirometry or even peak flow measurement unless the patient has their own and can do it in an open space. So we rather use the asthma control test or use your clinical judgment during this time, because we certainly don't want to disseminate or aerosolize that virus in our clinical setting, so we put our staff and other patients at risk. So wherever possible, you should avoid spirometry, but if you have to do it, I think there are recommendations by the South African Thoracic Society, American Thoracic Society, European Respiratory Society on how to conduct spirometry in the context of the COVID pandemic. It's not difficult to do, but providing you prepared and have the resources to adhere to personal and environmental protection measures, then it should be relatively safe. But avoid doing it if at all possible. Right, then there's another very interesting article that I just came across. And they did a study on how, because you see there's a perception that you got asthma, if you use a mask, you're going to have difficulty breathing, and therefore asthmatic patients are not going to be very compliant with the mask. And what they found in the study, and I've given you the reference in the Journal of Allergy and Clinical Immunology, that most asthmatic patients actually followed the mask guidelines better than non-asthmatics. And in fact, the asthmatic patients actually encourage people around them to do likewise. So that's a very interesting observation, because, again, intuitively you would think you got asthma, therefore if you wear a mask, you're going to have difficulty breathing, therefore avoid using it. And the opposite was actually true. And that's very interesting to observe. So patients' behavior sometimes surprises us. And when you looked at asthmatics who used the mask, about half of them said they had some problems breathing when they used the mask. About 40% saw no change in the asthma perception of their symptoms. And in fact, some of them actually reported an improvement in the asthma symptoms when they used the mask. I mean, obviously difficult to explain, but I think the overall observation is very encouraging that asthmatics found no problem and were far more compliant with using the mask compared to non-asthmatics. Right, so I think that's about most of what I wanted to say. I just want to end up with reference to the case that Neven presented. Again, I want to emphasize that when your patient with asthma comes in during the COVID pandemic, treat the acute asthmatic exacerbation on first principles. Secondly, whilst it is true that most times it's going to be due to COVID, keep your mind open to other possibilities. Because it doesn't mean that because you got COVID, all the other precipitants of acute asthma suddenly disappear. So the case that he mentioned, in fact, the patient was referred to my practice. We are a group of 3 people. So, and that patient did very well. But coincidentally, in the last 3 weeks, we've had 3 patients who came in with COVID and were severe asthmatic, but actually had influenza. So we've got to keep our mind open to other possibilities and not be totally, blinded to other possibilities just because we are functioning in the pandemic.
Well, thanks, Umesh. That was a fascinating case, a fascinating overview of what's happening in asthma and during COVID times.